Okay, so the waveform. So what does our waveform look like? So remember, we're the Magic School Bus, and we're sitting right here in the right atrium. So that's where you got to imagine that you're seeing things happen from, right? You're going to see the closure of the valve. You're going to see the atria around you kick. You're going to see the ventricle squeeze and push blood out. You're going to see the ventricle fill up with blood as well. So you got to imagine that's kind of where we're sitting. Okay, and again, the distal lumen of the triple lumen catheter. When you look at the PA catheter, it's actually the proximal lumen with the blue one there. And eventually those are going to either be proximal PA cath here, or it's going to be our triple lumen cath over here, right? And there's 3 bumps and 2 descents. So we have our ACV bumps here, ACV, right? And then we have our X and Y descents. So we're going to dedicate a slide each one of those. All right, so our CVP tracing, starting with our A waveform. So the A waveform is a result of atrial kick. So if you imagine we're sitting right here, right here in the right atrium, and then now we have this atrial kick. Everything around us squeezed really hard, and it then pushed all that blood into that ventricle, that right ventricle. So we're going to get this little deflection, and this happens right before systole. This is the tail end of diastole. The ventricle filled up naturally 80-90% of the time, or 89% of the volume was our just passive filling of the ventricle, and then the other 10 to 20% was the atrial kick, right? So all you're doing is you're kicking all that extra blood into the ventricle, right? So if you have AFib, are you going to have an atrial kick? No, right? You're gonna go, where's my atrial kick at? You're like, there's not gonna be any A wave. You're gonna see a C wave, you're gonna see a V wave, X descent, Y descent, all the other waves, other things you expect. But he's like, where's it at? Where's my atrial kick at, right? The atrial's like, I'm trying to AFib, I'm trying to atrial kick, but I can't, right? So AFib, you're gonna have no kick, right? So that's something to look at on your CVP waveform. You can say, oh, they definitely have AFib, right? Obviously, that's something you can probably see on the EKG. And then AV dissociation. So AV dissociation is you have an atrial kick, right? You got your C wave, V wave, etc. But then all of a sudden the ventricles, boom, it's going to contract on you, right? So it's all out of nowhere, right? So you're in there and you're going to feel that extra peak and this extra, what they're called canon A waves. Is it really an A wave? I don't know, but it's an extra spike when you don't expect it, right? You expect the doors to open up underneath you, the blood to fall in, yourself to kick, and then all of a sudden someone on the other side is like, not today, they're boom, they're going to kick, right? So AV dissociation is where you're going to jump, right? You're going to hit, you're going to get kicked back, right? So that's a atrial ventricular dissociation. So you'll see that in what kind of rhythms? A third-degree block, you'll see it in VTAC. So you can tell someone's like, oh, I don't know if they got VTAC or SVT with the Barron-C. It's like, say no more. Let me hook. You got a triple lumen catheter. We can hook that up and see if you have AV dissociation or not, right? So it just happens randomly. All of a sudden you have a PVC even. You got VTAC. You got a third-degree heart block. You're gonna have this canon A wave that happens, right? So the normal atrial kick is where you just jump in and you just kick into that full right ventricle down there, right? You're kicking in. Right, and then the other thing that we talked about before with like S3, S4 is like when this valve opens initially, you're if it sloshes in there, you get a S3 or S4. Which one was it? It was like a huge dilated right ventricle. You get a S3, right? But what if that ventricle is like super tight and it's like atrial kick, right? What's going to happen? You're going to atrial kick right into a post, right? You're going to atrial kick right, boom, right? You're going to get a little S4. You're definitely going to hear that noise real quick, right? So S4 is with a hypertrophied ventricle. Okay, so we're talking about this atrial filling process right here. So we get this little atrial kick, right? And that's the peak waveform on your CVP, right? And what should precede the A wave? So this is mechanical activity. There's my electrical activity. It precedes by about 0.08 seconds, right? So you can get your EKG and your CVP trace on the same page, and you can assess where my A wave is, because sometimes they all look the same. You say you don't know which hump is which hump. So you can say, oh, this hump is after the P wave, that's my A wave, right? And then C wave. So that's the closure of the AV AV valve, the tricuspid valve, right? So our tricuspid valve closes, and remember, we're right here, right? So we are closing this valve, right? So that valve closes, and what are you going to feel? you're going to feel that reverberation, right? Your tricuspid valve is going to close. You're going to feel it boom, 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 right? You're going to feel that closure. This is after the atrial kick, right? The atrial kick already happened. The valve is closed, right? Or the valve is closing. It's just closed, and then you feel that reverberation as the door slams shut, right? So ventricle closing, the tricuspid is like closed, boom, and then the other valve opens, and then it's time for ventricular systole right after this phase, right? Because we want that valve closed, why we are going to go ahead and eject the blood via the semilunar valves, right? There technically is no movement of blood right here because it's just closing, and the other one's going to open in that tiny little 0.04 milliseconds, whatever it might be, and that's where you're using the most myocardial oxygen supply. But what if you don't have a tricuspid valve? You're not going to feel this, right? You're not going to see it. You're going to have an absent C wave. But then what's going to happen next when the ventricle starts contracting? It's going to go up both ways, right? It's going to go up the pulmonary artery, and it's also going to go up into the right atrium there, right? So you see this huge V wave, which is representative of the ventricular contraction, which will come up on the next slide, right? So A wave happens after our P wave, and then we get a C wave as long as we have what's called a competent tricuspid valve. If we have a tricuspid valve, you're going to get a closure of the AV valve here, right? So what happens if you have tricuspid regurg? Again, you're going to have a split stream, right? It's going to go both ways. It's going to go into the pulmonary artery. It's also going to go into the right atrium, right? So you're going to see this huge waveform that you don't expect. A wave is no longer going to be the highest waveform on the monitor. All right, and X descent. So X descent, we got two descents. We got X and Y. So that's what's going to happen right after my closure of my tricuspid valve. We're going to see this huge descent happen. It's called the X descent. It's the first one that happens, right? So again, if you imagine yourself in the atria right here, we're right here in the atria, and all the volume is going away from us and like around the corner, whoop, right there up the pulmonary artery, right? It's going this way. If I'm sitting right there, I'm seeing it leave up that pulmonary artery, right? And it's you're going to feel that negative pressure as all the volume is leaving in front of you, right? So all that volume is leaving in front of you. You're going to get this descent, this negative pressure you're going to be pulled like into the ventricle almost, right? So you get this downward slope. X stands for atrial relaxation. They could have done better. They could have just called it something else, but they could have called it R wave or something, R descent or something. But it's atrial relaxation. That's where the X comes from. Okay, that ejected pressure causes a negative pull, right? If you have a really, really prominent X descent, right? You have this X descent like huge and ridiculous, right? You got this huge, huge dip. Like, why is that such a negative pull? Well, if you have like tamponade, if you notice like tamponade right here, it can't fill with blood, right? And when it can fill with blood, it is super, super thirsty, right? It's gonna really, really suck all that blood in if it can. Okay, it's also the reason why you have that alternating EKG complexes where it's big and then it's small and then it's big and then it's small, because it's literally moving around in the heart in the chamber of the chest that way. So it gets closer to the chest, it gets farther than the chest, closer to the chest, farther from the chest. All right, and then our V wave. So we're almost done with our different waves. We have the A wave, the C wave, the V wave, right? So our V wave is what is it? It's our filling of our valves, right? So the RA is filling up, as our ventricles were contracting, all that blood left. Our atria are behind us, right? What's going on? It's filling up with blood. It's like, whoa, what's going on behind me? I was just pulled closer to the tricuspid valve, and all of a sudden, all this fluid is coming up behind me and filling me up, right? So I'm going to see this V wave going to be as a filling up blood, right? At the end, during diastole, right? Sorry, during ventricular systole, my atria are filling up, right? Atria fill up so that when the ventricles are ready for blood, they're full of blood, right? So this V wave happens as we are filling up our atria with blood, right? And that's happening as our ventricles are contracting, right? Our ventricles contracted and cause that X descent, and now that change in pressures will allow our RA to fill, and then we can then go ahead and fill up, and that's going to cause our food baby to get born, and we have this filling up of our RA. Our pressures are going to rise because of this, right? What else? If we have really, really tall V waves, right? The reason why it's really tall and really difficult to get volume into that chest, right? Could be due to like tamponade, for instance, or we have RV failure. We already have a high pressure in our right heart to begin with, so it's really hard for volume to get in there in the first place, right? So then our Y descent. So Y descent is where we're sitting right here. Remember, we're sitting right there above the tricuspid valve, and all of a sudden it just opens and everything descends, right? Everything is going to fall into that ventricle. All right, it was filling up, filling up, filling up, and then the valve opened, and now we're going to fall into the left ventricle. 80 to 90% of our volume just falls in there, right? And then we are then back to the atrial kick. But that first part of ventricular diastole was this filling of the ventricle, and we're going to get that volume is going to open up, right? T-wave relaxation, and then the valve is going to end up opening up, and we're going to then, all this blood will fall into the ventricle, right? The ventricle is already full, right? There's tamponade, it's RV failure, pulmonary hypertension. It's going to be not that great of a slide, right? It's going to open like this, and you're going to fall like 1 foot, right? So it's not going to be as great of a slide if you have a ventricle that's really, hypertrophied, really constricted, or has more issues going on with it, right? So sometimes ventricle is thirsty, like we mentioned with tamponade sometimes, but like pericarditis especially, then it might just suck this down. You'll have a really, really dramatic dip in our Y descent. All right, so we're right over here where we have this tricuspid valve opening and all the blood is leaving the ventricle. And eventually it might kind of come up just a little bit as it fills up, fills up, fills up, and that'll kind of raise our pressure a little bit. And then it's like, oh, no, 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 no. And you're going to kick it back into the closet, right? So here's our recap of our different waveforms. Like AFib, are you going to have A waves? No A waves, or absent. If you have A flutter, what kind of waves are you going to have? You have A waves per day. It's going to be A. It's going to be all over the place, right? If you have AV dissociation, you're going to have what are called canon A waves. They're going to be all over the sudden. You have this huge PVC, or you have this huge episode of VTAC where you see all these A waves happen, right? If you had SVT, you're not going to see that. You're going to see the normal cycle of ACV, 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 right? And then tricuspid regurg, you're going to see a huge V wave because it's going to be, as the ventricle contracts, it's not going to be that descent you expect. It's going to be an actual big jump. Okay? RV failure, tricuspid stenosis, all these things would cause this slower descent and a rise in your CVPs most likely. And we got to compare it to the EKG because sometimes you can't tell which one's which. So it's, again, the A wave is after the P wave. All right, so abnormal tracings. So the other page was a little chart. Here's a little recap. If your CVP is more than 14, that is volume overload. You have too much volume in your heart, or your heart is not unloading appropriately, right? The right ventricle is failing. The tricuspid is not keeping fluid back, all right? It's difficult to get blood into the RV, right? So you're going to have this overall rise in your CVP. And then what about the A wave? Like we mentioned AFib, right? AFib, you're going to lose the A wave. So see the A wave is lost here, right? We have the C and we have the V, but where's the A at? It was lost because they went to AFib. And then we have A flutter, right? A flutter, again, we have A waves for days. So we have all kinds of A flutter. We have a peaked, like a really high pressures you can get with like pericarditis and tamponade and such, RV failure. But if you have canon A waves, that's where you have this, all of a sudden you have a really, really prominent deflection happening. If they're in a third degree block, you're going to see that pretty regularly. If they have like a real run of VTAC, you'll see that really dramatic rise in the A waves. And then if they have just like a PVC, just a little A wave, right? Like junctional P waves, you'll see that sometimes. Like it happens late, and and that can also cause an A wave, right? Because junctional is doing its own thing, but the P is like, wait for me, right? And then it's like it's not ready for the catch. It wasn't part of the regular P QRS cycle. All right, so that's our canon A waves. See these really big canon A waves that happen probably with some PVCs going on there, right? And then over here, we got peaked A waves because it's really, really hard to kick that fluid into that RV that might be really, really hypertrophied or really with RV failure. And then you can see here, look at this 20-point drop as we lost the atrial kick. We had A, C, V, A, C, V, A, C, V, and we went to AFib all of a sudden. You can see this drop in the CVP. You lost the A waves there, okay? You have atrial kick against a closed tricuspid. You have these canon A waves that might occur. right? No P waves, you're not going to get any A waves. So that's also something to consider. If someone has like a junctional rhythm, you're not going to see the classic A waves. Okay, so our other few guys to recap, right, are C waves, the closure of the tricuspid valve. We have they have tricuspid regurg. You're not going to get that closure. Therefore, that's going to be open the whole time. You're going to have these really, really peaked V waves. That's a ventricle, that you expect that, that to be just a little bit of ventricle contraction, but you're going to see this huge spike, right? Sometimes you might see a C wave in there, but usually it's this huge spike, and it's because of tricuspid regurg, right? The X descent and Y descent, again, you can tell the difference between like pericarditis and tamponade, but really usually a pericarditis is much, much more thirstier is kind of the way to describe it. You're going to see a really, really prominent Y descent compared to a V wave, right? The atrial is filling, 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 and then you have like pericardial restriction. You're going to have this difficulty to fill the atria. So you're going to have like a blunted response. Okay, so you can see here we have this really, really prominent rise in our CVP because we have a tricuspid regurg happening, right? You might see the normal A waves, but then you see this huge, huge V wave, right? Absent A waves means you have what going on? No A waves means you have AFib most likely, right? You have these cannon V waves. You probably have tricuspid regurg. You might have some, most likely tricuspid regurg. You can have it with like really, really bad RV failure, but then like cannon A waves, where were those from? So yeah, cannon A waves were from like a AV dissociation of some sort. So you see a prominent A wave all of a sudden out of nowhere. It's not like part of the regular CVP cycle. All right, so which bump is which? So that's where we get the EKG tracing. We can see that it falls behind about 0.08 to 0.10 seconds. All right, so it's about the width of a QRS almost. Right, so our A wave is after that, and then you can track it from there. ACV, 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 right? It's better to have a printout so we can kind of see which one's which. Okay, C wave, of course, is after, and then V wave's after that. So basically the first one you grab is the A wave. That's going to tell you which one's which. But if you don't have an A wave, then yes, you can see what's coming after the QRS. So the C wave comes after the QRS. Okay, you want to document strips Q4 hours. It's cool to have a CVP, but you have to document it. You can't just let it ride. You want to have something documented so you know that what you're doing, right? Hey, I got the CVP in place. They got AFib where they had cannon A waves. This is what happened, just like an EKG change. If there's an EKG change, we're going to be documenting it in the charts. Okay. So where do you measure CVP? So as we mentioned, peak and valleys are the different kind of the mnemonic for it. So with inspiration, expiration, you're going to be changing the pressures in the chest, right? Just like normal inspiration, expiration. But with that flips what we have someone on the ventilator. On the ventilator, you're putting positive pressure in the chest during inspiration, whereas when you're spontaneously breathing, you're making negative pressure in the chest, right? So CVP, which one is it going to be? Is it going to be 5 points up or 5 points down? Which one is the CVP? You want to make sure it is not affected by the respiratory cycle, basically, right? So if here's your respiratory cycle on someone spontaneously breathing, or the patient is breathing, and here's someone that is on positive pressure ventilation, right, or vent. So you can see here the CVP is always at end expiration. That's always the right answer, end expiration. But where is end expiration? You have to think about, is the patient breathing in on their own, or are they not breathing on their own? Because if they are breathing on their own, then it's just going to be at the end of expiration. That once, because they exhale at a positive pressure, we're going to grab it right before they come down that slope right there, right? You can't really measure a CVP on the way down. It has to be the last complex before it falls, right? Nice, not last even complex, I should say, before it falls. And then on the flip side, if they're vented, you're pushing pressure in the chest, and then you want it to relax. So you want it to be right at the last complex before it rises back up. Okay, so there's spontaneous versus non-spontaneous or positive pressure ventilation, where we want to grab our CVP value. Okay, and how do you measure a CVP? It's going to be measured. The number one thing is to measure at the C wave. It's the only hemodynamic that we measure the average of, or we measure the middle of. Most hemodynamics are measured as like the peak of, or the bottom of, or systolic, diastolic, or an average of 1/3 plus 2/3, or a flow measurement. But CVPs and wedges, for that matter, are measured right here at the C wave. That's the most preferred. The other way to do it is to take the peak and take the valley and divide it by itself, divide by 2, right? So take the average of the 2, basically. And that can also grab you a CVP value. So that's the recommended. The third one is to grab it down here before it rises, but monitors usually grab the average between the 2. Okay, but your monitors don't always accommodate for a huge respiratory variation. So that's why it requires us to go in to validate that it's true. Okay, so those are all alternatives. Again, we want to measure it at end expiration. All right, so our summary on CVP, again, it's a snapshot of what's going down, right? Most patients have no benefit if the CVP is more than 10. A lot of studies show that, oh, let's get the CVP up there, but it doesn't have any benefits, right? It should not be used for fluid status, but it should be used to look for the things we talked about, like tricuspid valve issues, if they have ventricular dissociation, if they have a tamponade or pericarditis. You can see if they're pacing or not pacing. You can see a lot of different problems with just the waveform itself, right? Or validate that they they have a more intervention or not, right? There is a poor man's CVP where you don't need an invasive line, where you need just a ruler, like a 12-inch ruler and a flashlight. It's like say no more, right? And you see, and you can go in the room, get them at 30 degrees, and then measure their impulse and add 5 to it. It's like, sure, you could measure JVD that way, but usually you're just saying they got JVD. It's like it's obvious, huge JVD, and you can see that. Yeah, you can see in tricuspid regurg and such, but or like in tamponade, or in right-sided heart failure, but you can measure it with a ruler and a effort, right? So that is a way to measure it, but again, it's not, is it valid? You have to make sure the user can do it right, and make sure they added 5 to it, right? Also, you might see them do the POCUS ultrasound, where they look at the inferior vena cava, and they see if it's collapsible or not to estimate what the CVP might be. And again, it's just like a CVP. It's not accurate for fluid status. You can't say, oh, look, it's super collapsible. Let's give more fluid. That's not going to work. Okay? But if your CVP is very, very high, you can say, yeah, definitely not more volume. That's not going to work. Okay? Passive leg raise is something simple you can do for your grandmas and for your patients that are hypotensive to restore blood volume. All right? Passive leg raise is a validated tool that is actually, very, very evidence-based, that says, yeah, if they respond to this 200 cc's of fluid volume that's in here, then perfect. That's going to work. Giving more fluid can be beneficial, right? So they're horizontal. You raise the legs up, and you see in 30 to 90 seconds if there's an improvement in their blood pressure. If they have an A line, you're going to see that pulse pressure variance narrow, right? If they have a CVP, you might see it rise a little bit, but you can see that their blood pressure improves as well. So that's a valid tool to assess if someone is responding to fluids. Okay.